Hello everyone, my name is Nkechinyere Ijioma. I'm an interventional cardiologist at The Ohio State University Wexner Medical Center, and I'm here with Dr. Kovacic.
Hi, I'm Professor Jason Kovacic from the Icahn School of Medicine at Mount Sinai, also from the Victor Chang Cardiac Research Institute in Sydney, Australia. We're here to talk about a paper that's just come out in Circulation Cardiovascular Interventions. It's a scientific statement from the AHA, the use of radial artery access for peripheral vascular interventions. And before we get into it, I'd like to acknowledge all the great people that we had on the writing committee with us. So I had the privilege of chairing this scientific statement. And what was cool about it was actually a collaboration from 4 different councils of the AHA. So we'd certainly like to acknowledge all of those councils, all of the authors, and particularly the AHA for giving the opportunity to us to write this important scientific statement. So Nkechi, tell us about what was the rationale for this paper?
Well, this statement was birthed out of the expanding indications for various endovascular therapies, the growing interest in adopting radial access for peripheral vascular interventions, and patient preference. So Jason, who should read this paper?
So yeah, it's a great question. The paper is going to be of direct relevance, particularly to those performing peripheral vascular interventions, but also for the care teams that are associated with that, all the other allied health professionals that are involved in the catheterization lab, other people that are involved in managing these patients that are having these peripheral vascular interventions. It's really been written with a broad spectrum of people in mind, including people that are international outside the States. So Nkechi, why don't you take us through what's the broad outline of the paper? What are the broad themes that we covered and some of the early messages we want to get across?
So the things that are covered in the paper are broadly the use of coronary transradial artery approach for coronary intervention and the benefits that we see in that space, and then also the growing interest in using radial artery approach for endovascular interventions, and the expanding field of endovascular interventions continue to expand across the world. And then we also talk about the limitations to transradial artery approach for peripheral vascular interventions and the advantages that still exist for a transfemoral artery approach.
I think it's a really important few messages you bring out there, that there's so much data now for radial artery use in the coronary field. And it's no surprise that interventionalists are increasingly interested in applying that knowledge that we've gained in the coronary field to the field of peripheral vascular interventions. And what we know from the coronary field is that radial artery access is patient preferred, it reduces bleeding complications, it's safer, and in some contexts it can actually improve mortality and significant outcomes. And there isn't that great depth of literature that we have in the peripheral vascular field, but I think that was one of the purposes of this scientific statement, was to draw all of that out and understand what is the literature and what are the main opportunities that we have in the peripheral vascular interventions field for using radial access to the advantage of the patient, for outcomes, and also for potential cost benefits to the hospital system. So there are a couple of key tables and figures, and I thought it'd be really helpful if we go over those tables and figures. So Nkechi, why don't you take us through table 1? What's the key message of table 1, and what would you like to highlight in that?
Yeah, so table 1 is really nice because it does tell us suggested indications and lesion types in which the transfemoral artery approach is preferred over the transradial artery approach when performing peripheral vascular interventions. It divides it into patient and lesion factors, as well as the technical and procedural factors. I'm going to walk the audience through this. So for patient and lesion factors, if there's an absent radial pulse or an incomplete palmar arch, or if there's subclavian artery occlusion or stenosis, is there Raynaud disease, or if the patient is tall, has a tortuous iliac anatomy, those are the times that you may want to consider not doing radial artery access, but rather going femoral artery access. And then looking at the technical and procedural factors, if a large bore sheath is required for the intervention, or if you need 2 wires for simultaneous vessel interventions, those are the times that you may want to consider as well going transfemoral artery for the procedure.
So I think there's a key message behind that table, which is that whilst radial access is really exciting, it potentially can improve outcomes, it's clearly not for every patient, right? And what I think this highlights is that patient selection remains key, and there's some patients that will do wonderfully with radial artery access, but there's some patients in whom radial artery access is just flat out inappropriate, and it's better to take a femoral approach. So, as is the case in most of medicine, individualised patient care is really key, although in a certain patient population it may be advantageous to take radial access. So why don't we then turn to table 2, and that is about which patients might actually radial artery access be preferred in. Could you take us through table 2?
Absolutely, and table 2 is really nice because it tells us why we're doing this paper and why transradial artery is growing and the interest is growing for peripheral vascular interventions. So some conditions in which you want to consider the radial artery access over the femoral artery access include when you have relative indications, such as when you have a patient that has previous iliac bifurcation kissing stents, or a patient who is obese, or a patient who does not have any palpable femoral pulses, or a patient who's had polytrauma with pelvic injury. Specific peripheral artery disease lesions in which the transradial artery approach may be preferred include when there's a stenosis rather than occlusion, when the lesion length is shorter, and when the lesion is above the knee. Jason, what about the figures? Can you walk the audience through the figures as well?
Absolutely. So there's 2 figures associated with this paper, and I'm going to do them out of order and start with figure 2. So in figure 2, we cover potential arterial access site complications that may arise from transradial arterial access, and these are ranked from less severe to most severe. Some of these are quite infrequent, minor hematoma, not that uncommon, but all of these bear consideration when contemplating radial artery access. In many respects, figure 1 is somewhat of a central illustration to this whole paper, and I think really does summarise some of the key concepts in contemplating radial artery access for peripheral vascular interventions. So in figure 1, we go over some of the advantages and factors favouring a radial or a femoral approach. So I think those 2 figures and those 2 tables really summarise some of the key concepts in this paper. The purpose of the paper wasn't to actually explain how to do radial artery access, so we don't go over things like the use of arm boards or the catheter lab setup. I think those are factors that can be actually well learned through many of the common ways that we have for learning radial artery access at the moment. So I think it is one of the great things that we bring out in the paper is that the state of the field now and the state of the knowledge is so different to where it was at about 10 to 15 years ago when we were just evolving radial artery access for coronary interventions. So what's unique about the situation for these peripheral vascular interventions is that we now know how to optimally do radial artery access. We know how to set the cath lab up, and there's the opportunity for cross-training between coronary interventionalists that know how to do radial artery access very well to train others that do peripheral vascular interventions perhaps aren't as familiar with this approach. So I think the field is at a very different position to the coronary field about 10 to 15 years ago. And whilst we don't have outcome trial data to show that radial artery access in peripheral vascular interventions improves things like mortality, we do know from some of the case studies that we present in the paper that it does tend to improve bleeding outcomes. And there's a clear pathway to the adoption of this approach for interventional procedures.
So while we do want our audience to go ahead and actually read the paper, what would be the key takeaway that you would give our audience as a teaser?
Yeah, I think the key takeaways from this paper are to say that individualised patient care is really important, and clearly, as tables 1 and 2 indicate, there are always going to be patients where one type of access, radial, femoral, or other, may be the preferred approach. And I think individual patient selection is key. I think the other elements that are key takeaways from the paper is that radial artery access has proven itself in the coronary field. We know it is preferred by patients, there's improved outcomes, reduced bleeding complications, and so it's reasonable to extrapolate that experience to the peripheral vascular intervention field, although we just don't know if it improves outcomes yet. And I think the third takeaway is certainly that there's a great roadmap for the adoption of this, but we do believe that outcome trials, ultimately looking at mortality, is really important in this field, because we do suspect, as is in the case in the coronary field, that more data is going to help better inform patient selection for the longer term.
So Dr. Kovacic, we want to thank you for leading this paper and working with the team as a multidisciplinary paper that was published by the AHA. And we advise everyone out there in the audience, go read the paper for yourself. And if you have questions, feel free to message us. Thank you so much.
Thank you.